Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Hey, it's my great pleasure to welcome back Ian Horsley for part 2 of our discussions on all things shoulder and what we agree on and what we disagree on. And in this session, we're about to dive into kinetic chain and the influence of the kinetic chain on shoulder pathology. So I'm looking forward to digging into this with you, Ian, because I think we're going to disagree in this space. But before we get to that, can you share with the audience some of your career highlights? Maybe if you look back across this enormous contribution you've made in elite sport and in the research that you've produced, what do you think are the contributions and what are the important parts of that for you? What sticks out most?
Okay, I think that there's probably two main things that that I was working with England Rugby Union in their wider support team through the 2000 up to the 2003 World Cup, which England won the Rugby World Cup. So being part of the wider team for that, rewarding to see the team do well. So that was really, really nice. And then a couple of years after that, I moved across to what was then the English Institute of Sport, now the UK Sport, and I have been incredibly lucky, and I've been selected for four Olympic Games. I did London, I did Rio, I did Tokyo, and then this summer I did Paris. And as I say, it's a tough selection process, and just because you've been once doesn't mean to say you'll get again. So I've been really, really fortunate to do those.
Yeah, and I imagine you are such a steady, level head in the environment that is quite stressful and demanding to keep the ball flat, as one of my favorite coaches used to say. Yeah.
I think so, but I'll reserve judgment. I'm sure there'll be loads of people putting messages on saying the contrary. They've worked with me, but yeah, I think I am.
Yeah, perfect. So let's dig on into kinetic chain, because this is a fascinating area for me, and I refer to it a bit in this space as a bit of a physioism. We have thought of this concept of kinetic chain. We can see how the concept might exist, but the research is massively lacking in this space. That for me then is quite concerning, because we tend to go down these rabbit warrens and then 20 years later think, oh, how did we get here? Before we start that, can you define for us then the concept of kinetic chain? Why you think it's important that we talk about this?
Because there's that concept of regional interdependence. So an area remote from their site of their pain or dysfunction can influence the outcome of that. And if we think about the kinetic chain for the shoulder in a person or an athlete who stands, then you've got the kinetic chain starting at the first MTP joint and then working its way up to the scapular shoulder, and then we can go down the elbow, wrist, and hand. And I believe that in some cases it has a big influence, but not every case. And I think that's part of the problem that we have in physio. It's all or nothing, and we know that all our patients are individuals, okay, and yeah. we can't exactly treat them the same way. I mean, I've learned so much from working in Paralympic sport. If you want to learn how to problem solve, work in Paralympic sport, you've got people who world record hosers in the pool swimming, and multiple medal winners in the Olympic Games who have weird movement patterns, generally without any problems, but then one day they'll come in and it is a problem. So working out what's happened and how to treat that is useful, and just thinking about how the kinetic chain sort of economizes the movement around the shoulder girdle. We talk about that 50% of the force produced around the shoulder comes from the waist down, 30% from the trunk, and 20% from the shoulder girdle.
How do we know that, though, Ian? How do we know? We're just plucking numbers.
Because Ben Kibler says so. That's
so let me get this straight. I have enormous respect for Ben Kibler and the work that he has done. But what do we know? Let's drill down to what we actually. We're just plucking those numbers, or we have evidence for that.
I think we're plucking that, and certainly we are trying at the moment to look at that. So especially about our return to play testing, about looking how the kinetic chain is involved. Let's say, if we do the closed kinetic chain upper extremity stability test, and we get a different score, we don't know whether it could be because they're lacking whatever we want to call it, core trunk stability, or whether they can't generate enough force through their glutes or whatever. So with it, so there's a lot we need to learn, but empirically, you can change somebody's movement quality, but also their movement symptoms by dealing with different bits of the kinetic chain, and whether that be muscle recruitment or that alternating sequences. If we go from the ground up and we start at the first MTP joint, we've got two options at a joint: mobility or stability. And in a standing athlete, then we want mobility at the first MTP joint. We need about 65 to 70 degrees of extension, or else that then affects further up the chain how the glute works. We want midfoot stability, so we don't want pronation or supination. We want ankle mobility, we want knee stability, we want hip. So we get this alternating pattern as we move on.
But how do we know this? Like, what's our evidence for kinetic chain? Because say we have that movement, how do we know that movement of the great toe influences glute firing? What do we have any evidence for that?
There are. I can't tell off the top of my head, but because if you don't, because then you're not getting appropriate hip extension if you can't extend it your first toe. There are some. I'm sure that I've seen a couple of EMG papers looking at that.
Yeah, in some of the space, I had this lovely chat with Anne Cools a few weeks ago around kinetic chain, and some of this may be the limitation in the research, like maybe researchers like trying to prove this concept is very difficult to understand, maybe because of the variability in the motor patterns or the way that people move is different. But still, I have some concerns, because my understanding then of the research is if you increase your kinetic chain load, that what we do understand is that your rotator cuff activity will decrease. But in my space, I'm thinking, well, maybe I want increased rotator cuff activity, not decreased rotator cuff activity. How does all that, how do I fit all this together?
Okay. With that, what you've just said there, what are you expecting of your rotator cuff? Why would you want more, or why would you want less rotator cuff?
So I think in the space of somebody who has shoulder instability, I would want more rotator cuff activity. So the argument would then be, based on that research, less kinetic chain would give me more rotator cuff. That's very simplistic, and I'm doing that really just to prove my point, but what are we dealing with here?
So what are we looking for from our cuff? If they've got instability, if we increase the activity of their muscles of the cuff, we're moving more to rigidity and stiffness from there, which will increase the compression. As I sort of mentioned in the last chat, it is, for me, it's about stability muscles. It's about that pre-activation that
Mhm.
certainly around the glenohumeral joint, we need the cuff to activate whatever 200 milliseconds before it moves, to just give that little bit of concavity compression, so that then your joint can move without any movement from the center. So for me, it's about timing. Okay,
Yes.
and we said
Yes.
last time about that beautiful effortless movement, and
Yes.
if we think about force production with it, that moves you more to rigidity and overloading joints, and some of, you can see in people who have had episodes of instability and have trained, then they get they get wear and tear, they osteoporosis at the joint, because they've got just massive compressions through there. And that's how they stabilize the joint, through unsubtle change in there.
And so the argument, like I completely agree with you around the timing of the movement and trying to achieve effortless movement. It's just so difficult to quantify. And my concern is, in the quest to then achieve this, we jump onto things that we actually have no evidence for, and are chasing in an effort to chase that holy grail, and I'm trying to, if we step back from that, what does that look like? And how do you then assess for deficits? Who do you think we should add kinetic chain for, and who shouldn't we? You said some people do and some people need it and some people don't. Who are they?
So one of the tests that I do routinely with all my shoulders, not just a spongy shoulder, is looking at a single leg mini squat, 30-degree knee flexion, and look at that we got hip, knee, and ankle alignment as they squat. They're not getting valgus collapse, the knee drifting in, or any rotation through the trunk. And if I see that, then I will look at that and try it and have an intervention, because certainly with it, I see a lot of failed sportsmen, not in the institute, from other professional sport, that have had reconstructive surgery around the shoulder that's failed. And when
Yes.
I've assessed them and I look at around here, around the shoulder girdle, it's brilliant. Everything's good. Lower trap, middle trap, serratus, all that is really, really nice. But I get down to the trunk a little bit, but mainly looking around the pelvis and that control there, not having that, and that's been my go-to as part of their rehab, which is quite funny in footballers when I'm telling them to take the trousers off and they keep saying it's my shoulder. Why am I taking my trousers off when it's my shoulder? But I'll show you in a minute.
And so you look at their single leg squat, and if you see some then deficits, you then treat it in my practice has been to identify deficits and treat them in a part practice way, and then combine them as I layer up their rehab. How do you do that? If you see somebody, like you say, with altered kinematics, shall we say, with that single leg knee bend, what do you do?
So then what I might do is then get them to stand on one leg and repeat their meaningful task. Okay,
Okay.
does it feel worse, better, or the same? Stand them on the other leg. Does it feel worse, better, the same? I might get them to do some resisted hip abduction against a band on one leg, or the other leg, or hip extension on one leg, and just look. So at the end of the day, for me, with all my patients, it is, are they getting better with the thing they came to see me with? Because they ultimately, that's why they came, because they've got a pain. I get pain when I do this, or I can't move here. Am I improving that? Can they do what they couldn't do? Can they move without pain? And that tells me I'm moving in the right direction, whatever that might be. From there. And again, it seems a bit. It seems a bit strange that I'm going to say this. I'm working, being a prof in academia and stuff like that. It's all about what I see, and numbers, and getting fixated on numbers, and is it reliable? If it works for that patient, it works, and I don't care, what the research says. If I can show that if you ask people at the Institute, what I do, I poke and stroke people. That's all I do. I literally, I will poke a muscle. I will poke a muscle to facilitate it and see if that changes the movement pattern. So just poking lower trap and seeing if that improves their movement or their outcome, or I'll poke serratus and see if that changes it, or I might poke them both together and we'll look at their quality and output. Because I've spent the last 4 years now reading lots and studying lots about sort of brain training, and that we know that, everything that we do is a brain exercise. And if we, for every input that we might put peripherally to drive a movement, that's one stimulus. But if we can get the brain does 30 stimulus down from there.
Yeah.
So if you can get the brain getting 30 times much more bang for your buck than you are doing it in traditional ways. So understanding, sort of the fear of movement, that if people know that a movement is going to be painful, then they're going to change. Your brain runs an engram before you move, runs it through your brain, and it's like, oh, this is what it'll feel like when I do this. You start to move, but your brain's also saying, well, I know it's going to hurt there. That response that you get from there to your brain is different. So straight away, your brain goes, that's not right. I am not happy. And it will give you a signal. And the only thing it can give you is a pain. And that's just saying, I'm a bit scared. This is to protect you, because the basic thing that our brain does is a threat detector. It's, from that primitive bit of the brainstem from there, when we used to be being chased by saber-toothed tigers, it has to analyze everything to make sure that we're safe. So if you hear some rustling in the bushes, it could be a saber-toothed tiger, so get the hell out of here. And similarly now, this is the thing. And so being able to de-threaten, move people in different, in different ways. There's some stuff we've been looking at from something I read the other week, is just changing the position that somebody's eyes are when they move can improve somebody's movement pattern, because the brain says, if I look straight ahead and I do that, that's painful. And then if I say, oh, just turn your eyes to the right, keep your head still, brain go, well, this is a different thing. I don't know what happens when I do this. Oh, that's a little bit better. So making sure that their output is a proper output, not a brain, I'm scared, I'm threatened. And by being able to de-threaten them, we can change stuff. And as I say to patients, if you can move once without pain, you can do it 100 times. There's nothing broken. If you had a broken leg, I couldn't do anything today to make you be able to walk without pain. But you've just gone into elevation. You said that feels great, right? So there's nothing broken. We've just got to get you to move better, drive yourself
in
better.
some ways, I've been using virtual reality in that space as well, to kind of trying to trick some of that brain movement. But again, I think that's very early days in this space. Can you, Ian, you have such a vast amount of experience here. And I understand that then for you to see the movement is enough for you to change that. But what about younger clinicians listening to this? They're like, well, Ian just looks at it and he can tell. How are they going to learn that? How do you learn that? What's your advice for young clinicians?
So the thing I would say to people is, don't look for anything, see what happens. Because if you start looking for things, you can convince yourself it's there. There's this phenomenon called the Baader-Meinhof phenomenon. So if you, like if I say to you, have you seen any purple cars today? And you'll say no. And then if you go out later, you'll probably see some purple cars, because it's just in the back of your mind and you're not particularly looking for it. So if you start looking for altered movement, you can convince yourself. That ability to stand away from your patient. So I say stand 3 meters away so you can see your whole patient and ask them to move, and just don't look for anything. And honestly, if you just stop searching, your eyes will pick up stuff. And it's not necessary, because you look at the shoulders, you might see, some pelvic sway or lumbar extension or whatever. So stop looking, see what's in front of you. And that'll help you, because if you start searching for stuff, you'll convince yourself it's there. And that's a mistake that people make.
That's my concern in this space. With such a lack of research here, where now people are going to listen to this podcast and then think, okay, so I have to look at their kinetic chain, and now we'll look at something and we'll see that it's different, but we don't know that that's important. So your advice to clinicians is step back and not look too hard and see what you see.
Yeah, with it, and again, because again, a lot of the stuff that we look at from movement is looking at EMG, and the problem is that when a muscle works, it's not all the fibers in the muscle that work, and it just happens to be, if we're lucky, we'll pick under the EMG electrodes, those will be working, but because muscles share work out, it might do, I'll do four reps with these few hundred things, but then we'll use these over here. Okay, and then that's why there's so much contradictory data, certainly around the shoulder, about timing of upper traps. Is it late? Is it early? Does it change if they've got impingement? Same for lower traps. And so understanding the limitations of the stuff we've got. But as I say, for me, at the end of the day, my patient is telling me what I'm doing is useful because they are improving. And if we get it right, they're good. And so I seem to be doing all right with my patients and this stuff.
And so if you were to describe this for younger clinicians, step back, look at what happens when you move their arms, look at what happens through their kinetic chain, do a single knee bend, see if that affects it, and then address some of those. Then do you drill into those? So maybe your glutes are weak, maybe you don't. Then you would drill into traditional strengthening in that manner, or
but
that's what you would do?
Facilitation, yeah. So I we talk about if we're looking at around, let's say, their scapula. So like Anne Coulter's paper in the BJSM from 2010, talking about the algorithm where you got strength and flexibility. I like that, but I amended it. I talk about muscle recruitment and tissue extensibility, because there are lots of reasons why muscles won't extend. Not just because if you've got a posturally changed muscle with loss of sarcomeres in series, you're not going to change that unless you're bracing. If they've got some underlying sensitized tissue under there and you release that, whatever you do, you're going to give them more pain. If they've got an imbalance between agonist antagonist from there, so what you do, you'd facilitate the antagonist. There's lots of things. And then the other thing is, if you've got somebody who's got a greater amount of muscle mass, like we find in athletes, then they are going to be stiffer because there's more connective tissue. It's like trying to stretch yellow TheraBand and black TheraBand. The color's irrelevant. It's just that black TheraBand is thicker than yellow TheraBand. So understanding that. And then similarly, they keep saying about, it's not about strength for me. It's about muscles activating at the right level at the right time. You don't want you don't want everything. Strength's not everything, and it's way down my rehab program. I want onset. I want quality of it, and then once we've got good movement, we can load strength and we can load speed on that. But if you're loading strength and speed on a system where the time is wrong, it's like driving your car when the tracking's out. It's going to wear your tires out from there. Whereas if you sort your tracking, you can bomb up and down.
How do you teach patients the timing? So there's a patient who doesn't have the correct timing. How do you go about changing that? Because I hear what you're saying. Strength is not everything, and we know how important we know how important the control of that is and how important the brain is in performing these functions. How do we go about changing that? We think perhaps timing might be altered. What do you do?
That's a good question. As you're asking me, I'm thinking, what do I do to change that?
How does it change?
I think one of the things is to de-threaten them. So go through stuff about, what I talked about, the brain protecting and things. And then look at making sure, because again, they come in and they get quite stressed. If you can relax them, we'll look at breathing things, but just me poking stuff, literally poking the muscle and say, can you feel, once they can feel good movement, they say that feels so much better. Yeah.
Can we just agree that we call it facilitation, not poking?
Yeah, facilitation. Yeah, oh, and yeah. So my stroking is I inhibit muscle by pulling across the fibers. Yeah, and then poking. Yeah, in line with the, yeah. So facilitation, inhibition, and
I think we should dig into that, because people don't necessarily understand what you mean by poking and stroking.
Oh yeah.
What does that mean? Explain that to us, how you do that. I think that's important.
So if you're talking around the shoulder, so the main culprits that you find when you've got issues around the scapula are lower trap, middle trap, upper trap, and serratus. And so you will often find that you have insufficiency, whatever you want to call it, of lower trapezius. So if I'm watching somebody move and they need 60 degrees of scapular upward rotation, and we'll see what their outcome is, have they got pain, what the quality like, and I will literally just poke lower trap and just ask them, does that feel
with a single finger into the muscle?
Yeah, so I'll go into, look, so come off the medial border of the spine of the scapula and just go down, because it's on that, it's on that 120 degree there, so poke just below there and we'll see what happens. Or I might come round the side here and poke serratus. Because for me, what's about that brain training is, that there is, and it's debatable, this thing that they call sensory motor amnesia. Basically, if you're not getting output action from a muscle, your brain forgets it there. Therefore, it can't send a message down to do something. So all I'm doing is saying, I'm here, find it. And that's, that's what I do. Yeah.
And I traditionally, when I think about what I do, I've used some mirror feedback, and I like to call it, facilitation, where I'm probably stroking along the muscle as opposed to poking with my finger. But it's probably the same thing, isn't it?
Yeah, and we might use some mirror, to de-threaten. We might use mirror therapy, watching the contralateral arm move and see how that is. We might even use neuromuscular electrical stimulation. So I might use Compex. So on lower trap and serratus, and one of our PhD students a while ago did a nice paper looking at how stimulating lower trap and serratus individually or together change the subacromial space.
Right.
With it, I think if you did lower trap and serratus together, you got like a 0.9 millimeter, 95 millimeter increase in subacromial space, which is about 7 millimeters at rest anyway. So that's not a bad change if you think 0.95 millimeters is a small number, but based on when you've got as a space of 7. But and they gave about 0.6 each on their own when you looked at facilitating there.
And so can you explain then the cross fiber thing there? So explain that is different than the poking.
Yeah, so obviously, what we see a lot of, and that overactive upper trap. So again, by just pulling across, upper trap's going. Let me show you. It's going that way down my shoulder. Yes. So I'm going to pull my arms across it that way to inhibit it.
Yes.
Okay, and well, does it change? As I say, if it might not, but it takes 3 seconds. It's non-invasive, and the patients, I'm just asking for feedback from the patient, because and the reason why I do that, because from ages ago, reading about taping. If you want to facilitate, you tape in line. If you want to inhibit, you tape across. So I thought, well, just why? I don't.
Is that true though? Is it true?
I don't know, but like I say, I don't. If it works, if it works, does a rabbit's foot make you lucky? No, but it makes people be able to. It makes people be able to do things because if I get the outcome and it's not dangerous and it gets us to good quality movement, so they can experience good quality effortless movement. That's it, because that's what your brain's just said. That's what I am looking for, right? I know what I'm trying to find now. I've got that motor pattern. I've got that engram.
Okay. And which kind of segues us from here into some of the vibration work that you've done, because you and I have talked around the effect of putting like wearables and vibration onto devices, onto muscles to look at. Then I was really excited to read some of your work around changing perhaps what happens at the glenohumeral joint. Can you tell us about that?
Yeah, so we've done a couple of things at Liverpool Hope around this. We used well, the first studies that we did, we used a vibrating platform, so a power plate. We put
Yes.
we had EMGs all over the body, and we had three options. We had them standing on the power plate, and they were holding a band that was attached to the power plate. And we put the power plate on, so the power plate was vibrating and the band that was attached to the power plate. So at 90 degrees flexion, that was whole body vibration. We then stood them off the power plate, but they held their band while the power plate was vibrating, and that was arm vibration. And then we just stood them on the power plate with the band with no vibration. Okay. And in all the vibration states, we got increased activity of the muscles, but also in the whole body vibration one, we got some earlier onset of some muscles, some of the rotator cuff muscles, and some of them were inhibited as well. So that was quite a nice study to start with.
And I think that's what I was really excited to read about in your work, because similarly as you, I'm looking for that timing of activation and that early onset. And I have started some discussions there with a company in New Zealand called MyoVolt, where they put these vibrations on the muscle. And there's still lots of work to happen in that space, isn't there? But perhaps the vibration changes the muscle recruitment or the onset times, or stimulates your Golgi tendon organs.
Yeah, I think it's giving you some proprioception, but we know that vibration changes muscle tone, but both positively and negatively. So it can increase muscle tone, it can decrease muscle tone with it. And I do think I do things with a vibrating ball in the hand. Okay, from there, and I'll get them to move, and then I'll give them the ball not vibrating. We'll get the movement, then we'll switch it on, and probably 6 times out of 10 there'll be an improvement in their functional task with just having some vibration.
It's fascinating,
through the shoulder. Yeah, I think.
Yeah, which kind of takes me back then to our first discussion, where we were talking about, proprioception and impact, and the work you had done in the rugby players and the contact collision, because that loss of proprioception is not driven from Golgi tendons, is it? Whereas we think, because you're coming from capsule labral receptors, we're thinking, whereas the vibration is very much muscle driven, isn't it?
Yes.
It's fascinating the way all these different things combine, and how your brain then utilizes all that information to change movement. It's
The more we know, the more we realize we don't know.
Yes, I think so.
And we're heading to a place where, rightly or wrongly, what you think is okay, something might work, but we must know exactly why that's working, or else we can't can't use it. And for me, as long as it's safe, I don't get too hung up about it. I want a good outcome for my patient, and if it's safe, if it works, if it gives them that beautiful effortless movement, that's good, because if they can experience beautiful effortless movement, they know what they're working towards, and it gives some feedback to the brain, and it can sort it out.
And would you necessarily record that for them to remind them of that, or that's something?
We video, we'll video it, and what I'll show them, especially obviously when we're looking, a lot of it is looking from behind and what's going on with the scapulae. So I'll video that, and they can see, and then we'll come around the front, as we talked about, what happens to clavicle positions and things. So they're getting and what I tell them to do is, right, look in the mirror and you're doing something which is now is pain-free and not, look, that is you. It's all about getting to your brain. Remember this, imprint this on your brain, because that is you stood here. I'm not touching you, we're not doing anything, and you're pain-free. Just remember this, imprint it on your brain, because that's what we've got to do. We've got to convince your brain that this is you. And that's I send them away doing beautiful, effortless movement, and when it's not beautiful and effortless, they stop. It might be, and each time they do it, I'm not going to say do 20 or 10. I'll say do as many as you can until you can't. And if you get to 30, stop, because that's plenty. But if you have a go at one and it's not good, and the second one's not good, leave it for that minute. Don't stress about it. Leave it. Remember, have a think what we do, and next time you came, run that video that you've got in your head, or look at the one on your phone. That is you, and see if you can find it again.
And reinforce, and that must be incredibly empowering to your patients to be able to check that, see it again, reset, and then go again.
Yeah, I'm trying to work myself out of a job in practice. I don't want them to need me, because most of the time, I'm saying, you are driving yourself wrong. Okay.
Yeah.
You've got to learn to drive yourself better. I can't drive you. I can sit in the seat next to you and advise you, but I can't take control of how your body moves. You've got to do that yourself. And we've got various means that we may or may not be able to do that.
Do you have any final comments for clinicians around kinetic chain, or anything else you think is important for clinicians to remember in the assessment and treatment of shoulders across the globe? What do you think is important for clinicians?
I think doing mini tests as part of your assessment is most important. So rather than thinking you have to go through a full series of examinations, I think a really, really good subjective examination, that's the biggest bit that people skimp on. And you should have 80% of the information you need to make a diagnosis from your subjective. And then for me, I do my subjective. I have a mental list of top 3 things that I think it could be, and I'll dive straight in and say, right, if it's an AC joint, then that's probably going to be painful, and that's probably going to be
the horizontal flexion and an O'Brien's is what you're showing for people who are listening.
But resisted abduction and external rotation won't be painful. All right, that's good enough for me.
Yes,
it looks like an AC joint. It smells like an AC joint. Right, I'm going to treat this AC joint.
Yes.
And then we'll retest their meaningful task. And I will do something, and I go back to my patient. Is it worse? Is it better? Is it the same? If it's getting better, right, we'll repeat it until we either is better or we get a plateau, and then we'll look at something else with it. So mini testing within your assessment, I think, is much, much better, will help you a lot, rather than doing 100 tests and having all this information and not understanding it. And if you can change a person's movement pattern or their symptoms for the better, then they've got faith in you. If you can show them something just within 10 minutes that things are better, then you've got them, and you've got time. Then they believe in you because you've made a change.
And that's incredibly important, isn't it? Getting that patient buy-in. So what I'm hearing from you, despite your jovial poking and stroking, you are doing a very, very thorough subjective examination, choosing your key diagnosis, and then doing some other clinical tests to confirm or negate those different diagnoses, and then moving into a plan which then creates that patient belief, and that then affords you a bit more time. Is what I'm hearing.
Yeah, so just to go from the other end of me stroking and poking, yes, I am creating a hypothesis and a null hypothesis, and I am testing my hypotheses.
It's been absolutely wonderful catching up and chatting with you. That's been really delightful. I really appreciate your time.
Thank you very much. Thank you for the opportunity, and looking forward to catching up with you when you come over to Sheffield later this year.
Yeah, we're looking forward to coming. So yeah, we'll see you in September, isn't it? Sheffield. Yes. You and
6.
I talking instability and return to sport is our current plan with the team from USAB. So we're really looking forward to that. We'll see you then.
Okay, right, take care. Thank you.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.